Good morning, everybody. I'm Dr. Kirti Gunasekara, and my co-chair is Professor Khandi. And this is the first symposium of this session. Without much ado, let us invite the speaker to the podium, and he will be speaking on basics of allergy and clinical approach to an allergic patient. He's an eminent physician from USA, and I think his CV is over there, and he's no stranger to us. Over to you, sir.
Good morning. Ayubowan. I'm very happy to be here in this beautiful island of Sri Lanka. This is my second visit in the last 6 months. We were here on an excursion when our medical college in Mysore had a 100th centenary celebrations. We were about 75 doctors from Mysore Medical who were here and enjoyed your whole country. Thank you so much. One thing I noted was your country is much cleaner and doesn't have bumps on the road. So, which made a big difference for us when we were traveling. So this topic that is assigned to me is basics of allergy and how do you approach an allergic patient? That is the topic. So let's look at the basics. What is allergy? When I was in medical college, I would tell my friend, I'm allergic to the professor, I can't handle him. That is more of a psychological type of word, very loosely used. But since 1968, that has changed. Since the discovery of IgE, it has become an immunological reaction. This is when the marriage of immunology and allergy occurred. Now, when we say allergy, we mean it an immunological reaction. And actually, it is not only immunological, but also it's an exaggerated immunological reaction against substances that are generally harmless to most of us. We don't worry about dust mite, cockroach antigen, cat antigen, dog antigen, pollen. None of those are even seen. They are all microscopic. But how is it? Immunologically, it bothers you. We have what we call as immunological eyes. You have your own eyes. When you go to bed, your immunological eyes get very active, overactive actually. And that is what protects you. The immunological eyes will detect these antigens, and depending on your genetics and environmental issues, your immune system can form IgE antibody against it. So, we also use these words called atopy, sensitization, allergy. These are separate words, but we use it synonymously. What is atopy? Atopy is a genetic state. Say like I have an individual who does not have any allergy symptoms, but he says, my uncle has allergies, my mom had allergies. That means he's genetically wired. He comes from an atopic family. That is genetically he's wired, but does not have to have any symptoms. Sensitized. Say like you're 100 of you, I skin test all of you with dust mite. 50 of you will react. 30 of you will have some symptoms. Some 20 of you will not have even a history or sensitization. What it means is 50 of you who reacted are sensitized. 30 of you who had symptoms are allergic, and 20 of you do not have either. So what it means is you do not have to have allergy when you are sensitized. That is the message. You may have antibodies, but does not mean you will have to have allergy. So that is one very important thing for us when we skin test patients or when we do specific IgE, we call it immunocap, which is a trade name. We found that there are many, many reactions that show up, but do they mean anything? They do not mean much except saying that a specific IgE antibody is present there, but do not have to have symptoms. So that is why correlation is very, very important. So these are some sentences, but sound a little confusing. You can be atopic, but not allergic. That is just what I told you. You can be sensitized, not allergic. You may have positive skin test, positive blood test, no symptoms at all. But you can be allergic and not atopic. There are few exceptions like insect allergy, drug allergy, latex allergy. You don't have to have any history then, but you can have a major reaction to it. And if you're allergic, generally you are always sensitized. So why am I showing this picture? These are a diagrammatic picture of epithelium. There are two genetic defects in allergy. Allergy is a classical gene-environmental interaction disease. What are the two defects genetically? First defect is defective epithelium. The defect is the apical junction, the tight junction, hemidesmosome, desmosomes, and all these different anchoring agents that anchor the cells to the basement membrane are all weak. And the cement between the cells is compromised. So that means it's a leaky epithelium. It's a leaky epithelium. Even atopic persons have a leaky epithelium. Allergic persons definitely have it. So what it is a leaky epithelium. And because of the leaky epithelium, a lot of these environmental pathogens are what we call as allergens, viruses, pollutants, chemicals, gases, volatile organic compounds. They enter through the epithelium. So allergies are caused through skin. That is very important. Food allergy especially enters through the skin, not through your GI tract. And when I say epithelium, you are talking about skin, respiratory tract, GI tract. If you look at the total epithelial surface of those three major organs, it is equal to 50 to 100 feet around us. Each one of us has 50 to 100 feet around us interacting with the environment. So that is the amount of exposure you have to the environment. You have to just imagine it. It is not 5 feet 4 inches. It is a huge area that we are exposed to. These are the skin, mucous membrane, respiratory tract, and GI tract that interact with the with the environment. Second defect is your T cells. T cells are skewed towards acting on the Th2 pathway. So when it is stimulated, in the genetically prone people, instead of Th1, we go towards Th2. We, especially Asians, have the tendency to react to the Th2 pathway. So we are all Th2 pathway. Majority of us are more Th2 pathway. So we are very sensitized but may not be allergic. That is what we find in the food allergy. When we did the study in India, 26% of our children were sensitized, but only 0.11 were allergic. So there is a huge difference between sensitization and allergy because our population is got the tendency to get sensitized. And so we have huge number of autoimmune diseases because our immune system is very, very overactive. And that is one of the reasons why our IgEs are 3 times more than in international standards. International standard is 150. Ours runs around 500 to 600. We have an overactive immune system genetically. So this, I'm going to go really quick because of the time sequence. This is a typical diagrammatic fashion of the hypersensitivity reaction. So what it is first is what we call as a first exposure, re-exposure. First exposure, the allergen, which could be pollen, it could be dust mite, whatever, it could be food, comes through the compromised epithelium, picked up by a very intelligent cell called antigen presenting cell, which is right in your skin or in your respiratory tract. It's called Langerhans cells. It's also called a dendritic cell. It's called by different names. What it does, picks up the antigen and chops it up, so that any allergen has got carbohydrate, protein, and fat also. But what the antigen presenting cell does, it chops it up and presents only the protein part of the allergen to the T cell. And these things occur in your lymph nodes, in your lymphatics, not in your blood. So all these reactions are occurring in your lymphatics. So when it is exposed to the T cell, the T cells will look at it and say, I don't like this particular protein, looks foreign to me. So let us get IgE antibodies against it. So it will tell the next neighbor, the B cell, to produce IgE antibodies. That is called class switching. The main function of the B cell is to antibody production. So class switching happens, the IgE production happens, and the IgE is present in 2 forms. One is free circulating IgE in your blood, and there's a bound IgE which gets bound to the mast cells and basophils. And once the IgE gets bound to the mast cell, the character of the IgE changes. The half-life of generally IgE is only 2.5 days, but once it gets bound to the mast cell, the half-life is 6 to 7 weeks. And it is very firmly bound. So it is present now in your skin, mucous membranes and all that. That means your mast cell is armed. So next exposure that occurs, and there will be what we call as a coupling reaction. It goes, two identical IgE antibodies goes and hooks onto that antigen. Coupling reaction happens, and that causes a release of preformed mediators like histamine, kinase, tryptase, and that causes your allergic reaction. The symptoms, the triple rhythm, the triple reaction like erythema, redness, swelling, which we learned in physiology class in medical college, and that happens immediately. Then at the same site, 6 to 8 hours later, there are two other substances that are formed, which is prostaglandins and leukotrienes. And these, what they do is that they draw all these different cells, eosinophils, lymphocytes, neutrophils, and there's an intense inflammation. And that is what the inflammation, what we call as a late phase reaction, that is what we treat with inhaled steroids. When you put your patients on inhaled steroid, what you are treating is the late phase reaction, not the immediate reaction. So, if you look at the lymph node morphology, you take a cross section. It is very interesting. In the lymph node, there is a what we call as a T cell area and a B cell area. And this is where most of the reaction occurs, where the T cell is exposed to the particular epitope and tells the B cell to form antibodies. All these reactions occurs in the lymph node. And it is not unusual with acute allergic patient to have lymphadenopathy, painful. It's not infected. It is inflamed. It is allergic inflammation. And because of the reaction in the regional lymph nodes. So, I already told you about this early phase and late phase. IgE, the important point was not discovered for a long time because it is present in so small amounts. It is present in micrograms. We did not have the technology until 1968 when the Ishizaka couple, Terihoko and I forgot, Kimishake, Teruko Ishizakas, from Japanese couple, very hardworking couple, actually found the IgE in the same institute I did my fellowship in Denver, the Children's Asthma Research Institute and Hospital. 4 years prior to when I joined fellowship there were 2 rooms down our, wherever we used to work, 2 rooms down, that's where the Ishizakas worked. And that is where the IgE was discovered. And it is called IgE because E is the substance that produces erythema, but the other reasons also. But at the same time, Johannesson in Uppsala, Sweden also discovered IgE. And the way he discovered IgE was much easier, and he was very lucky because he had a patient with B-cell myeloma producing tons of IgE, lots of IgE in that particular patient's serum. So that patient, serum had a lot of IgE that could be easily measured, and that patient became very rich by selling his serum to many pharma companies. Now, the one thing I forgot is very important is it will not cross the placenta. It will not cross the placenta. Very important. I don't know, this is not working. Oh yeah, it's working. That is, it won't because of the molecular weight. So, if you take a cord blood and you measure the IgE, all that IgE is coming from the fetus. Fetus immune system is mature at even 8 weeks of gestation to produce the IgE. That means the B cells are developed, T cells are developed, it can interact. It is mature already. It is capable of producing IgE antibodies at age 6 to 8 week gestation. So whatever IgE is present in the cord blood is coming from the fetus. So that is sometimes used as a screen. So risk factors, the most important risk factor is family history. That is where the genetic occurs. And there's another thing, it has got all these different reasons there. I cannot go through all of it. But one thing, small family size is another very, very important, interesting type of item that we need to address. Now, it is not unusual for parents to have 1 child, 2 child. If there are 3 children, everybody raises their brow. 4 means there's something really unusual. So what used to happen when we were children, we were like 6, 8 of us in the household. In my own family, we were 12 or 14 of us, because everybody after marriage stays, it was a big joint family. So each coughing on each other, fighting with each other, spitting at each other. So with a lot of microbial exchange. 3 brothers, we 3 brothers used to sleep in the same room. So we used to have a lot of microbial exposure there. Okay, but not anymore. There is very little microbial exposure. And everybody is too clean, putting on this antibiotic, minute the child has any running nose, runs to the doctor. A doctor is very anxious to give antibiotics, and he writes the antibiotic, and he wants to see the next patient. And then everybody wants to use the soap. Oh, be clean. You should use soap every time. You have a little dirt, use the soap. And also with this COVID coming, you got also the special lotions that you put on. So everybody is becoming less and less microbial infested. So it is actually messing up our microbiomes. And that has really will cause several different diseases. Allergy is one of them. Clinical approach. Let's see. A typical allergic patient is always a little anxious. Amazing thing, an allergic patient, he is happy if you tell him you are allergic. That is the paradox that we have. If you tell someone you have asthma, he is not happy. But if you say allergy, yes, I got allergy, good, I'm happy now. If I don't have allergy, I will go to the next doctor. He will find some other allergy with me. So that type of issue is there. And that particular person has many questions. He's confused, and he is sort of wants answers for everything, and he's looking for a cure, because they did a survey in the US, and they wanted to know how many health providers this patient has seen before I see me. They found that they have seen 12 other health professionals before seeing a specialist. So they already have many different views. Some of them could be very confusing, contradictory. So what they need more than pharmacotherapy, more than any other therapy, these patients need what we call as education. They need to be educated first. That is what is necessary to do, not just pharmacotherapy. So what are the 3 ways of diagnosing allergy? Very easy. History. Not history, skin test, IgE and all that. So history is the most important, because history plays a major role in diagnosing allergy. So we depend on history. So a detailed history is most important. Physical examination is partially useful. Allergy skin testing is complementary, as well as serum IgE. So, but as I already told you, you will be sensitized to many things that may not be clinically relevant. So that is why you have to do what we call as clinical correlation. That is, you correlate history with the skin test findings to find out which is significant, with what is clinically significant. That takes time to know. So now coming to the case, I will go fast here. I know Dr. Niranjan is looking at me. So Arjun is a 6-year-old, presented with itching, nasal symptoms, sneezing, and he also has persistent symptoms daily, year-round, perennial, mostly indoors, aggravated in late summer, early fall. Again, so he has seasonal flare-ups. Occasionally, he also has night cough, and he has been also wheezing a couple of years ago and had nebulization. So basically, what has happened to this little kid is he has got impaired quality of life because he is not able to sleep well. They have found that patients with allergic rhinitis, 80% of them have 8 to 10 microarousals every night. 8 to 10 microarousals. That means sleep pattern is very poor in these patients. So when they get up in the morning, they're tired, grouchy. So they also are moody, and they get up sneezing because of dust mite sensitivity. And their school grades fall because they go to sleep at 10 o'clock in the morning because he has not slept well at night. So it is a disorder not of the nose or eyes, it's a systemic disorder. The same interleukins that are produced, it affects your brain, affects your muscles, it affects all over. So it's a systemic disorder. All the diseases that we have are all systemic disorders, and allergy is one of them. So environment history, except dampness, ventilation is poor, those are important. But family history, mother has asthma, and that is very important. Maternal history is very important for us, more than paternal. Maternal history is very important for us. Physical exam, he has got pale nasal membrane because of the thickening and inflammation. Clear lung fields. And other than that, cervical nodes are palpable. Other than that, he is fine. Now, let's look at what is my thought process. As I am taking the history, my thought process says, this patient has some symptoms consistent with mast cell activity. That means he has itching, sneezing that is reacting. Some chemicals are released. Some mediators are released, histamine release. Consistent with inflammation, looking at his nose and all that. And suggest both upper and lower airway involvement. And symptoms seems to be progressive. That means he started with upper airway symptoms. Now he started having lower airway symptoms. That is progressive symptoms. Also, his symptoms are nocturnal. He coughs at night. And these are not just localized, these are systemic symptoms. So, physical exam, not a whole lot of usage there. And when do we say disease is progressive? This is an important point because there is nothing like a test for it. This is a clinical type of impression. These are what we call as clinical pearls. So when you see the patient and the mother says, my child was doing well on 3 times medicine. Now, if I miss 1 dose, he has more problems. Or she says, I used to give 1 teaspoon of the medicine. Now he needs 1.5 teaspoons of medicines. Or she will say, this used to work very well, but it is not seemed to be. But I'm quite happy compared to before. He is better. But now in the last month, I have been seeing that he also has a cough. He has a little bit, when he runs, he has got some, seems to cough more than the others. But overall, I'm not very upset about it. So what it means, these are subtle things which the mother is telling you. And these are subtle things. There is no guidelines for it. These are subtle things that will not be picked up by any test. This is subtle thing that you have to pick it up by patient interview. That is what your sensitivity towards the subtle things should be significant. That is when you make up you will come to know there is some clinical progression. So in pediatric patients, what we do is we retest patients. We test patients every 6 months to 8 months, just 5 or 6 skin tests. And we see that the reaction, like the dust mite reaction, gets bigger, or they get neosensitization, they get some newer sensitization, which means there is immunological progression. The clinical symptoms suggest clinical progression. So if you have both clinical progression and immunological progression, you need to think about allergen immunotherapy. This is important. Clinical progression, immunological progression, you start thinking about allergen immunotherapy. Reason is, none of the medicines we give, inhaled steroids, antihistamines, antileukotrienes, they all work at the tissue level. And I have told you in the diagram, what drives the whole thing is a T cell. So allergy is a T cell disorder. Allergy is an epithelial cell disorder. Allergy is not IgE. Don't get carried away with that. It's a T cell disorder. So unless you treat the T cell, patient will not get much better. So allergy skin testing is a great screening test, well correlated even in children, safe, reliable, sensitive. We are going to have a workshop on it. I'm going to go through this more than a blood test. One word about blood test is, please do not do total IgE. Total IgE is a useless test. So screen allergies. Because even if you have a normal total IgE, all that normal total IgE level could be directed against a specific allergen. Do not do total IgE. Do not do any of these panels, because there's a lot of pressure on you from different companies' labs. Please do panels, sir. And especially general doctors, you say, I'll do the panel. Let's see. The mother comes and says, can you do this blood test for me? And you say, yeah, it's easy. I'll write it for you. But please never do it, because we know there's a lot of false positives. And Indians, Sinhalese are not anything different. We are very too close and we have similar type of environment. We are all high IgE producers. This is Indian data. We came out of our work in Mysore, where we looked at 30,000 children due to Europe Revolve study when we did that. And we found 31% of our patients had total IgE between 300 to 1,000. It was not uncommon to have 700, 800, and they did not have any significant allergies. So we are non-specific producer of IgE, because so many things are in our environment. Our immune system is overactive. So this is a major type of discrepancy between skin test and IgE. So spirometry, how will you treat? Explanation, education is the most important. Environmental control, pharmacotherapy, immunotherapy. And these are the epidemics, fact or fiction. I just told you this is a lifestyle disease. Many different factors will influence it. Approach with an open mind. Let the patient speak more than yourself. So they did a study in the US. How many times do we interrupt a patient when he is taking history? 18 times. 18 times we interrupt a patient. Let the patient speak. History provides a diagnosis. And thank you so much.
Thank you, Dr. Vedanthan, for sensitizing all of us on basic concepts of allergy and how to approach to a case of allergy. We'll have the question and answers at the end of the session.
Okay.
I request Dr. Kirti Gunashekhar, the chairperson, to hand over a certificate to him.
I can get at the end of the session.
Okay. Please come and join. we'll go for the next session talk from Professor David Dane. I think we heard him yesterday. He has delivered a wonderful oration yesterday on bronchopulmonary allergy. He is going to speak on severe asthma with fungal sensitization. Sir, please go ahead.
Great. Thank you very much for the opportunity to talk about this topic, which is quite a challenging topic in many ways because the definitions are not perfect. So you can't talk about SAFs without talking about ABPA a bit. And ABPA is probably pretty common in Sri Lanka. We think in India, it's probably 2 to 3 times more common in asthmatics than it is in Western Europe and the US. Maybe 5% of adult asthmatics have ABPA in India. And there's probably even more patients with SAFs, although it's much less diagnosed. There's a lot of commonality between these two areas, but you get more bronchiectasis with ABPA than you do with SAFs. And the criteria for diagnosing SAFs require, of course, to have severe asthma, whether that's brittle asthma, whether that's critical asthma, all the different forms of severe asthma. And you all know that the definition of severe asthma varies a lot, and it's a disease with remission as well. But you also have sensitization, and that's a key element, sensitization to one or other fungi, and that's a key piece. So some patients with asthma, and severe asthma particularly, are big mucus producers. They have a sort of mucus phenotype, but ABPA patients have a very specific sort of mucus, which is incredibly thick and often is a little bit brown. And you can get a story of a patient producing brown sputum. It looks a little bit like slugs, and it's very difficult to get up. And in ABPA, that results in obstruction of airways, and you get exacerbations. And an exacerbation is an airway blocked off by a mucus plug, usually with a big rise in IgE. And that's usually resolved with high-dose steroids, but sometimes you need bronchoscopy, as in this case, to actually remove that plug and take it out. And the other feature, which is very distinctive for ABPA and seen, as far as I know, in no other condition, is this hyperattenuated mucus. So on the bone windows, you can, of the scan, you can see this mucus, which is very white and very distinctive. You can get bronchiolithiasis with even higher levels of Hounsfield units that are up in 200, 300, but more than 75 Hounsfield units is the typical criterion for diagnosing a ham feature. And the problem with ABPA in particular with these mucus plugs is illustrated by this woman who was doing really very well with itraconazole, and then she decided that she wanted a baby, so she came off itraconazole because azoles in pregnancy are contraindicated, and she then had a relapse as she was breastfeeding, really quite severe relapse, as you can see, with a complete right upper lobe collapse. And when she recovered from that after steroids, she's left with a lot more bronchiectasis. So mucus plugging leads to progressive bronchiectasis, and it's one of the reasons why we try and prevent that problem. So those are my comments about ABPA, and we need to diagnose that. And the studies that have been done for treatment many of them are focused on ABPA, and there's slightly fewer studies focused on SAFs. And what you get in SAFs is much more bronchial thickening than bronchiectasis. You can, of course, have bronchiectasis either as a consequence, but more commonly as a sort of comorbidity problem with patients with severe asthma and fungal sensitization. And so patients can have more than one disease, in other words. Okay, so there are lots of interactions with fungus and asthma. So fungal and damp exposure in the home increases the risk of development of asthma. It also increases asthma severity, and it increases asthma exacerbations. So there's 3 components here, not just one, 3 different things going on. There's an entity which I'm sure you are aware of, a thunderstorm asthma, which is partially driven by by fungi. There are other things that drive it as well, but you get these episodes where multiple patients arrive in emergency room with asthma attacks. There are some occupational diseases linked to asthma, and some of those are fungal. So mushroom picker's lung is an example of that. Tobacco picker's lung is another one. We know that fungal sensitization is linked to severe asthma. There's quite a strong link there. And we also know that antifungal therapy reduces asthma severity in most patients with both ABPA and SABs. So there's quite a big and complex interaction going on here. And it's made more complex in other ways. So it's not just one fungus. There's loads of fungi out there. We think there are several million species of fungus in the world, somewhere between 1 and 3 million different species, of which we named about 150,000. Alternaria is a big, big player in here. Aspergillus is a big, big player. Cladosporium is a big player. Rhizopus less so, but there are other fungi that also are less important, but they do cause problems in some patients. And we haven't got a complete list of all the fungi out there that can cause fungal allergy. So this interesting study looked at the exposure to various things in the home, particularly mold, and associated that with the development of asthma in children. So nearly 300 children, and a quarter of these children developed asthma by the age of 7. That's a huge rate, but they chose them, I think, because of the family history. The homes were assessed when they were 8 months old. They looked for dust. They looked for endotoxin, cats, cockroaches, house dust mite, antigen, and they did a fungal molecular assessment as well. And that was compiled in a thing called EMRI, which is a mold index. And they found a statistically significant association with these high mold exposures with the development of asthma, an odds ratio of 1.8, and Aspergillus acraceus, unguis, and Penicillium variabile, all fungi that you probably have never heard of and don't care about, but the risk with asthma is really doubles in these patients. It's quite a big issue. There's also a exposure in adolescents. So this large study from a big European cohort looked at 7,000 young adults, and they looked for only 2 fungi, Alternaria and Cladosporium, and they assessed the homes. And the key output in those 7,000 children was the 355 children that developed asthma. And there was a correlation with water damage and mold in the home over this period of time. And the risk ratio for new asthma is 1.46 if you had water damage, or 1.3 with molds. So as you, I'm sure, know, molds have spores or conidia, which you can breathe in. And those conidia are actually completely silent immunologically. We don't respond to the surface of these conidia at all. They're taken up by macrophages and epithelial cells, and they're killed. And all of us have a little bit of fungus. If we took a little bit of your fungus, your lung out today, and did a fungal culture on it, we would find a bit of fungus in there. So there's a constant recycling of fungus going on in the lungs. And because these spores don't have an immunological reaction, it's only in those who get a exposure to either the hyphal fragments, which I'm showing in this slide, or if the fungus germinates and uncovers inside the spore coat other allergens and antigens, which then drive the fungal reaction. So once you start to have bronchiectasis, once you start to have lung damage, the process accelerates because you then allow fungus to survive in the lung and cause an ongoing immunological reaction. And this group from Australia, Brett Green and Johan Tovey, looked at these immunological reactions, and these different fungi produce these different preformed allergens which drive asthma. And there's a there was an interesting study, both adults and kids with who had uncontrolled asthma in Puerto Rico. And you can see that the mold exposure in both the adults and kids were significantly associated with ongoing severe asthma, whereas cockroaches and smoking had no impact by contrast. And actually, there's not a strong relationship with house dust mite and asthma either in other studies. So it is the fungal exposure that is the driver for this. And we're going to see more of this with mold and flooding and damp homes. This is going to be an issue. This is a slide from a house in Hurricane Katrina, but this is a relatively common problem in many, many homes, unfortunately. And we have a big problem in the UK with this as well. So you can approach this, as we've heard, by doing skin testing. That's the cheapest and simplest way to do this exposure for sensitization. You can also send specific IgE tests to the laboratory, but the challenge is which ones do you send and how much that costs compared with skin testing. Or you can make a presumptive diagnosis based on exposure from the history. Now, this relatively complex slide tells a few stories, and I don't want to go through all the different proteins that are listed in these ASBEF things. But the first thing to say is that Aspergillus fumigatus has 70 different allergenic proteins. It's the most allergenic thing on the planet in terms of the number of things that it produces, which we can react to. The second thing about this is that there are multiple homologs or very, very similar proteins in other fungi that drive it, and sometimes non-fungal proteins. So even there's some of these which are very similar to human proteins. And there's a supposition that you have almost an autoreactivity where if you're sensitized to a couple of these Aspergillus proteins, you then have an ongoing almost autoreaction internally. And so there's a very complex interaction here, and it's big. And so all the testing you might do in the lab will never get to the bottom of all of these different interactions. There's too much to explore in a clinical scenario. And if you ask the question, how many different fungi, and you can see that's a complex question. This is a study where we looked at patients with severe asthma in adults in the northern part of the UK. And many people are just sensitized to one fungus, but others are sensitized to multiple fungi. So you have to screen, if you're going to really try and cover this field, for multiple different allergens. And that's quite a challenging problem, and you never feel you've quite got to the bottom of it. So how would you approach this from a treatment perspective? So this is a list of all the randomized studies that have been done looking at ABPA and SAFs and other things in there. And I'll talk you through some of these without going through the data, apart from two of the studies, which I think are quite interesting. We've participated in some of these. So natamycin we used for fungal keratitis. It was used as an inhaled in a very small study in the UK. Did not have any benefit at all. And then itraconazole was found to be definitely a benefit in a study that David Stevens, who was my mentor in the US, did. And that was the first sort of really key study published in the New England Journal. And then there was another study done from Southampton group, Dr. Walk, which also showed benefit. There's one of the other little things here is that there are some patients with fungal skin infections or dermatophyte infections. And the dermatophytes on the skin have common allergens with Aspergillus and Alternaria. And so one of the things that we need to do is to undress our patients and check if they have a dermatophyte infection and treat that, because that might improve their asthma. So I don't know, hands up, all chest physicians who look at the toenails of their patients. Not many. And that's a problem, isn't it? Do you take the shoes off? Do we look for tinea pedis? And actually looking for, in these patients with severe asthma, looking for dermatophyte infections is something that you can do to improve the patient's asthma control. All right, it's a simple thing to do, and it's relatively helpful. So this trichophyton asthma was a randomized study in 11 patients with a significant p-value. So when did you last see a randomized study of 11 patients with a strong p-value? So that tells you something about the power of identifying and treating the fungus related to these diseases. And then there was SAFS, which is a study we did with about 60 patients with a strong p-values as well. A not very well designed study from Leicester, did not show benefit with voriconazole. There were lots of reasons with this. It was a different enrollment criteria. They treated for 3 months and looked for an outcome at 12 months. Not very clever design, I don't think, in many ways. Anyway, and then there have been some really good studies from India looking at ABPA patients, comparing with steroids, itraconazole, voriconazole for acute exacerbations. And then the studies I want to talk to you about are 2 studies actually from Iran, which are quite intriguing. Oh, so we're not moving forward here. So this study looked at patients who had severe resistant asthma. So another phraseology for a group of patients. And their outcomes were verbal symptom score, including sleep, the FeNO, spirometry, Asperger's IgG, and tolerability. And you can see that they randomized the patients here to 10 milligrams of prednisolone for a month, and then they did an evaluation, or itraconazole at 200 milligrams twice a day. So the standard dose of itraconazole is 400 a day. Some patients do respond with 300 or 200, and we very rarely use more than 400 a day, just so that you understand the dosing there. And that was treated for a month of comparison, and then they treated for 4 months. And the standard duration of that first block of therapy with antifungals is typically 4 months. And sometimes patients do better if you give longer, and sometimes they relapse if you stop therapy. But 4 months is the typical duration that's been used in a lot of the studies. So in this study, what happened at 1 month, these are the first 2 blocks of prednisolone versus itraconazole. And you can see that there were some patients who didn't respond to prednisolone, but the benefit of itraconazole was clear at 1 month, although it wasn't profound. Some of the patients didn't complete therapy. So this is a weakness of this study. There was a lost to follow-up problem. And there was some side effects. You can see that 12% of the patients stopped steroids in a month and 6% stopped itraconazole. So we do have side effects with itraconazole. And one of the problems is an interaction with the inhaled steroids. Another is a peripheral neuropathy. Some people feel sick. You get a tremor in some patients. So there are some issues with itraconazole. It's not a perfect drug by any means. And then at 4 months, you can see that there were 70% of the patients who stayed on study who felt completely better. Severe resistant asthma, 70% fine. That's a big impact. That's a big impact. And this was statistically significant. And then they did a study, and this is the FEV1s. So there's the itraconazole went from 1.6, the FEC to 3.1, and the FE1 from 1.3 to 2.4. So improvements in their lung function as well. So this was a physiologically benefit, not just the symptom scores. And then a similar group did a follow-up study where they actually looked at bronchial wall thickness. And the reason for showing you this is because this shows, if you like, a morphological improvement, which is helpful. And you can see in these bar charts, which are a little bit hard to read, that before treatment, you've got mild, moderate, severe, and extremely severe asthma, another phraseology. And some of the patients in this black bar had severe asthma, very severe, extremely severe asthma. And with itraconazole, that went down. So did it also with prednisolone, but there was a placebo group as well. And the placebos also improved. As we know with asthma, you usually get some improvement with placebos. But what they then did was to take the right apical segmental bronchus, and they used a software program to assess that pre and post therapy. And this is illustrated with this diagram on the left. And with itraconazole, you can see you had a reduction in the wall thickness, which was small, 2.29%, but statistically significant. Improved, but not statistically significant with prednisolone. Probably if there'd been more patients, it would have been. No change with placebo. And likewise, the wall area improved in the same pattern as well. So you've got a morphological improvement in these patients with severe persistent asthma. So some of the patients that you have, doing testing is too expensive. You don't want to do it. It's a problem, and and so on. So these studies raise the question of whether we should be trialing antifungal therapy, particularly if there's a mold exposure at home in these patients. But first, we should certainly treat their dermatophyte infections, because that's an easy thing to do, and that will improve patients' success. We did a little bit of work for patients who couldn't take itraconazole with inhaled amphotericin or using a nebulizer. This needs to be done, if you want to do this needs to be done with physio support, because many of these patients get quite significant bronchospasm. And you can see that was a problem in half the patients. But we did end up with a small number of patients who had persistent improvement and could take inhaled amphotericin. So if you fail with itraconazole, and I should say we've also used voriconazole with success, and we've used posaconazole with success, but if you fail with itraconazole because of toxicity and other concerns, this is another thing to try. But there's only a small number of patients who you can actually get to tolerate it who benefit. But if they do benefit, they really benefit. A couple of other points. There's a lot of fungus in our bedding, in our pillows at home. So Ashley Woodcock, who has led our group in Manchester for many years, we took 6 pillows and analyzed them. And there's lots and lots of fungus inside these pillows. How many colony-forming units per gram of pillow? I don't know how many grams of pillow you have, but 300 kilograms of pillow or something. The 2,700 colony-forming units of aspergillus. And we didn't look at duvets and blankets and other things. So this is another type of exposure which is not usually looked at or thought about too much in these patients. And Jean-Pierre Gagnou, who's based in France, in Rennes, looked at whether you could actually improve the home environment for patients. So no, not pharmacological at all. And they took a group of patients who had very severe asthma, all adults, and they removed the visible mold. They ventilated the home. They got the patients to open their windows at least 15 minutes every day. Right. So some people just don't open their windows. And they collected the dust. They did a lot of cleaning. They used a HEPA filter on on the vacuum cleaner to try and get rid of this. And they had a mattress cover if they had house dust mite allergy, although I don't know if that's important because there's an RCT showing that's not important, but they did that. And you can see a very significant improvement at 12 months with the uncontrolled asthma going from about 70% down to about 10%. So there are environmental approaches to handling this as well as pharmacological approaches, and home ventilation, reducing mold at home and so on, I think is an important component of all of that. There are 2 companies developing inhaled antifungals. Cipla are developing itraconazole, and Pulmicide are developing a new azole called obuconazole, both in phase 2. They're not focused particularly on SAFs, but that's an area which may be useful in the future. So in conclusion, airborne fungi are allergenic, and exposure can both induce asthma and make it worse. There are many different patterns of disease, and there may be genetic variants underlying some of that. Antifungal therapy is partially effective for improving asthma control, and when it works, it's very profound. It's really very effective. And oral antifungal drugs have some side effects and are problematic in terms of drug-drug interactions. So one of the things, if you use itraconazole, after 1 month, you should reduce the dose of inhaled steroid if they're on high-dose inhaled steroid, because we've seen patients getting Cushing's syndrome and just flattening their adrenals completely and having no adrenal function subsequently. So just be cautious about that issue. And with that, I will stop. Thank you very much for your attention.
Thank you very much, Professor Denning, for that very interesting talk on fungal sensitization. We will have the questions at the end of the session. And now it's my pleasure to invite Dr. Hitasha Rupani to speak on the biologics in asthma and the phenotypes. Yes, over to you.
Thank you. And thank you for inviting me. My name is Hitasha. I work in Southampton. I lead the severe asthma service there. And I am going to speak about biologics. And some of you may know that this is what I do day in, day out. So I can speak about it all day, all night in my sleep. So I'm going to be grateful for the bell that's going to stop me. I have some disclosures. You'll notice that I'm not favored to any one company. So it doesn't affect what I say today. What is the scope of severe asthma? And this is European data. So if you take 100 patients with asthma, we know that about just under a quarter are going to be on high intensity treatment. And that means high doses of inhaled steroids, additional controllers, often a LABA or a LAMA. That's about a quarter of patients. Just under 20%, so 17% of those patients will have uncontrolled symptoms. They have ongoing symptoms despite this high-dose treatment. But we know in these patients, it's mainly because they're non-adherent, they're not taking their treatment regularly, or they have other major comorbidities such as really bad reflux disease, really bad sinonasal disease that's not treated. And if you come down to it, it's less than 5% of patients have severe asthma. And so that's the group that, at least in most parts of Europe and in England, that we target with biologics. Not all the rest of it, just that sort of under 5%. It'll come as no surprise to you that the impact of severe asthma is tremendous. So they say that 50% of the total costs associated with asthma are because of severe asthma. People with severe asthma have 5 times the increased risk of or frequency of hospital admissions. And when you look across the world, so this is data from the International Severe Asthma Registry, and what it's showing you is the percentage of people internationally that have had 1 exacerbation a year, 2, 3, or 4. And if you look at the group that have 4 exacerbations a year or 3 or more, it's almost a third of patients worldwide have more than 3 exacerbations a year if they have severe asthma. The data from England is even more shocking. It's up to sort of 70% of patients in England that have severe asthma have had more than 3 exacerbations a year. And then if you put that together, you can see that actually people with severe asthma in the far right column there have increased costs. And most of those costs are linked to their treatment costs. What's not always looked at is what does the treatment cause? So we know that steroids have side effects, and this is an Italian study. And what they showed that, again, people that have severe asthma having frequent course of oral steroids, treating the steroid side effects is also costly. So it's not just the disease we're treating, but we're treating the side effects caused by us giving patients treatment. One of the things we've now started to find out more and more about steroids is that their side effects are cumulative, but they're also dose dependent. So this graph here is showing you patients that are taking prednisolone every day. And, you could apply this to any of the other respiratory conditions. You can apply it to ILD. You can apply it to patients that have sarcoidosis that are on steroids every day. And it's broken it down by steroids that people that take steroids less than 5 milligrams a day, which is the sort of grade star, 5 to 10 milligrams, which is the blue square, and then over 2 milligrams, which is the red triangle. And you can see there is a dose-dependent increased risk or incidence of a number of side effects. Now, we always think about things like osteoporosis. We always think about things like cataracts. But actually, what this study showed is not just those side effects. It's things such as increased risk of infections. They come in with pneumonia. There's increased cardiovascular risk. They have increased risk of sort of MIs and heart failure. It's not just people that are on steroids every day. If you take more than 4 courses a year, in this study here, again, there's an increased risk. And what's even more shocking is that even after a single course of steroids, there's your risk of fractures is doubled, your risk of venous thromboembolic disease is increased 3-fold, and severe sepsis 5-fold. Now, this is a question I get when I do my ward rounds, and I'm sure some of you do as well. When you start a course of steroids, and my juniors go to me, well, if the risk of severe sepsis is 5-fold, why should we give them steroids? And what I say is actually we have to treat it acutely because it's life-saving in that situation. But we then need to think about what can you do to reduce their risk of needing steroids in the future. And that's where biologics come in. So often when I show this picture, people start to switch off and think there's too many numbers, there's too many letters, there's too many cytokines. So I'm going to just talk you through it in 3 really simple steps. So bear with me. So we all know that the epithelium is really important. We've heard this morning about how it's really important in allergic reactions. It's also really important in asthma. And you have your triggers. Again, we all identify them. Patients come and go, oh, I get a virus and my asthma gets worse. Or, oh, I was in a room full of smoke and I got worse. Or I had an infection and I got worse. got the allergens there as well. So these triggers activate the epithelium, and the epithelium releases a range of alarmins. The main one for now is TSLP, just there. And what the alarmins do is that they activate the ILC2 cells and TH2 cells. These are the two main cells because they release three main cytokines. Okay, so we've gone from one alarmin to two cells to three cytokines. And the cytokines are IL-5, which you can see in the middle there is activating eosinophils, causing eosinophils to degranulate. And then you have IL-4 and 13 that work sort of almost synergistically, but also in slightly different pathways. IL-13 works to increase the production of FeNO from the epithelium. It works on smooth muscle cells to cause them to be more twitchy. And then IL-4 plays a key role in sort of that B cell class switching, which will lead to a release of IgE, which then goes and sits on the mast cells, which we've heard about this morning. We also now know that there's almost a sort of a T2 independent side, which you can see on the far right-hand side there, which works via mast cells as one cell type, but there's probably others there as well. So you've got your eosinophilic inflammation side, and then you've got your T2 independent side there. So when you come to looking at severe asthma endotypes, if you open a textbook or you Google it, there'll be at least 15 listed. You can endotype severe asthma in a number of different ways. And, I think that it's sometimes good to simplify things. And in my simple mind, I think there's two ways. You've got T2 high, which is T2 inflammation high, or T2 low. And that's it. Those are the two things you need to think about. And we always get asked, well, what do we do about T2 low asthma? And luckily, it's really, really, really rare. So we've looked at our cohort in Southampton or across Wessex. And what we found is that if you actually look at those patients and you go back and you look at their historical blood results, their historical biomarkers, in our cohort there, less than 2% of patients never had a T2 signal. Across the world, when they looked at it, it's about sort of 80% have a T2 signal at any one point. And how do we identify that signal? We look at biomarkers. So this is from a Scottish cohort, and they looked at the prevalence of the different biomarkers. And they found that actually, as a snapshot, when you look across the patients, it's less than 20%, again, would not have that signal when you look at them at baseline. And if you look historically, as you found in our cohort, it's less than 2% won't have that T2 signal. So you can be pretty happy that if you're going to look at severe asthma, you're going to be treating a patient that is T2 high. So the biomarkers I just mentioned, those three biomarkers, what do? Well, they're measurable, so we can measure them on a day-to-day basis. They can indicate the disease that I've shown you, but also they help us phenotype and endotype the patient, which is how we get to biologics. So I'm just going to talk to you about those two biomarkers. So you've got your eosinophil, and the eosinophil, as you can see, plays that key role. It increases mucus production. It causes epithelial damage. It activates mast cells. It plays a role in remodeling through release of TGF-beta. And the eosinophil is probably my favorite cell, I would say. And I like it because it's easy to measure. Everyone has a full blood count done. And the higher your eosinophil, the higher risk of severe exacerbations. But also what you can see on this graph is that the higher your eosinophil count, the worse your asthma control is going to be. So it's linked to both exacerbations and control. And across the board, this is data from the International Severe Asthma Registry. Eosinophilic asthma is really, really common. Over 80% of patients across the world that have severe asthma will have an eosinophilic phenotype. So that's the eosinophil. The next biomarker is FeNO. And again, similarly with FeNO, the higher your FeNO, the increase your risk of exacerbation. So it's a really good biomarker there to think about how are we going to treat these patients. So coming back to the figure I'd shown you before, now that you have an understanding of the eosinophils, the FeNO, the three main cytokines, you can see that if we block different parts of these pathways with biologics, we can try and improve disease control. So you have one of the oldest biologics on the left, so omalizumab, which will block total IgE. And then as I work my way through, you've got dupilumab, which blocks IL-4 and 13. The two main ones we use most commonly in England at the moment is mepolizumab and benralizumab, which block IL-5 and reduce levels of eosinophils. And then this new one at the top called tezepelumab is termed an upstream biologic because it works higher up. It blocks TSLP. And again, I'll talk very briefly about that towards the end. Now, when you think about biomarkers, I've said that they're measurable. So you can measure eosinophils and FeNO. They help phenotype the disease. But, I think we should, as clinicians, expect more from these biomarkers. And really, I think a biomarker should be one that can help prognosticate, but also tell us how people are going to respond to treatment. So how do the three biomarkers do? If you look at eosinophils, so this is a post-hoc analysis of one of the biologic studies. And in the gray bar, you can see patients that received placebo. And what the graph is showing you across the bottom is increasing eosinophil levels. And across the y-axis is number of exacerbations. And you can see the higher your eosinophil count, the more exacerbations that patients are receiving placebo, the gray bar, are experiencing. Whereas if you treat that with benralizumab, the number of exacerbations comes down. There's a direct link. Similarly with FeNO, the gray line is placebo. The green line is people that receive dupilumab. And you can see the higher your FeNO, if you receive placebo, you're going to have more exacerbations. If you treat that, the number of exacerbations goes down. What about IgE? This is increasing IgE down the bottom, and you can see the exacerbation numbers is flat. So the higher your IgE, you're not going to have more exacerbations. It's not linked to exacerbations. But if you block eosinophils here, like they did with benralizumab, the number of exacerbations comes down, regardless of your IgE. So what that says is that the blood eosinophil count is a great biomarker. It's easy to measure. Look at it. Patients have full blood counts on all the time. And treating it prevents exacerbations. FeNO is also a biomarker of risk. And if we indirectly target that, where you can with dupilumab, you prevent exacerbations. Whereas the total IgE is not really a biomarker of risk. And as we've heard from this morning, it's not really doing anything there. It's a number and people can have it raised for other reasons. Very important in ABPA. I'm not going to say no for that. So what do we have currently licensed? Those are the 5 main biologics that we currently have licensed and their indications written down over there. And which patients would we use it on? Now, in England, we have pretty strict criteria, but across the world, use of these biologics is based on biomarkers and based on exacerbations. The threshold is set differently in different countries. This is what they've decided to set it in England. But you can see it comes down to what your biomarkers are and how many exacerbations you've had, because that's what the biologics will try and reduce and prevent. Across the board, they all, as I said, reduce exacerbations. They're all steroid sparing. They've also been shown to improve lung function, which is helpful for many patients. You'll all know patients that have severe asthma that have really impaired lung function. They get referred from the COPD clinic because people think they have COPD because they have such marked airflow obstruction. And even in those patients with sort of what we think as remodeling and have fixed airflow obstruction, we're starting to see improvement in their FEV1. And across the board, they all improve their quality of life and measures of asthma control. They affect your biomarkers differently. So tezepelumab on the top, as I said, is an upstream biologic. It'll reduce the levels of all of those biomarkers because it's acting at the top. On the far left, the ones that target eosinophils, so mepolizumab and benralizumab, will only reduce the levels of eosinophils. Dupilumab will reduce your FeNO and may actually even increase your eosinophils slightly. And then finally, on the far right, omalizumab only targets your IgE. So actually, it targets very, very single part of that pathway compared to across the board like the others do. So I'm going to go through a couple of cases now. So the first case is a 48-year-old lady. She worked as a lab technician at the university next door to us. And she had adult onset asthma, having very frequent exacerbations every 2 months. She didn't smoke. She was on high dose treatment, and she also had nasal disease. And these were her biomarkers. So you can see her eosinophils were up, her FeNO was raised, and for what it's worth, her IgE was raised as well. And we did some more investigations. She had sort of quite marked airflow obstruction for a 48-year-old, but there was still some reversibility there. Her CT scan was very typical of some of that asthma, lots of bronchial wall thickening and some air trapping. Almost all my scans show that. My patient scans, not mine. And she was sensitized to grass pollen and house dust mite. So when we work somebody up for a biologic, this is a sort of algorithm that goes through my mind. And the first thing that we do, as I said, is you confirm the diagnosis and you phenotype the patient. So her phenotype was adult onset. I've said atopic and eosinophilic. I should say allergic after this morning's talk, but atopic and eosinophilic asthma. And that's what her biomarkers showed. So you're going to think, okay, are you going to target her atopic disease? Are you going to target her eosinophilic disease? And luckily, we've got some data to show that for people that can have both, targeting their eosinophilic disease using an anti-eosinophil biologic, the anti-IL-5 or 5 hours, are much more effective than just treating a single part of the pathway with anti-IgE. This is data from the International Severe Asthma Registry, where they've compared a matched cohort of patients, that received one or the other, and the patients were matched for all other characteristics. And what you can see on the left-hand side of each graph is the anti-IgE, the right-hand side is anti-IL-5, and the anti-IL-5 biologics have a much better impact on reducing exacerbations, a much greater impact on reducing hospital admissions, and a much greater impact on reducing maintenance oral steroid dosage. You can look at the other way. So this is UK data, and this is looking at patients that received benralizumab. And on the left, you can see those that were atopic, and on the right, the ones that were non-atopic. And you can see by targeting eosinophils in both these patients group, there was a similar, very significantly good impact in reducing exacerbations, but similar regardless of whether you were atopic or not. Now, there's no head-to-head trials that are there that are helping us choose between the biologics. So how do we do that? Things that you can look at are patient-related factors. You can look at their comorbidities. You can look at biomarkers. And there's a big thing about shared decision-making. What does the patient want, or what's best for them? So when we think about sort of patient-related factors, one of the things that we sometimes think about is age of onset. And there's some data, all post hoc, to show that perhaps that is important. And so the graph here, well, the one on the right there shows with benralizumab that possibly if you have adult onset disease, you do better than if your onset is less than 18 years. In the middle, the graph shows tezepelumab, which shows actually it makes no difference what age of onset the disease is. The response is just as good. And in the bottom, there's dupilumab, which shows that actually the older you are when you have your asthma onset, the greater you benefit with dupilumab. So over 40s have greater benefit than if they're under 18. But the response is seen across the board. Another thing that we look at a lot is steroid dependence. And we know that some biologics are slightly better than others in reducing oral steroid usage. What about biomarkers? Again, this is all post hoc. There's some data to show that if the higher your blood eosinophil count, the greater your response to mepolizumab. And if someone has a very high FeNO, for example, I might tend to choose a biologic that targets that more directly. So dupilumab or tezepelumab. Again, there's no head-to-head studies. Comorbidities is something we always look at. And nasal polyps now is an easy one to think about because there are biologics that are licensed for the treatment of nasal polyps in many countries, so dupilumab and mepolizumab. So if we've got a patient that has polyps, we'll tend to, again, choose one of those biologics. And then finally, shared decision-making is an important thing. The dosing schedule does come into play, and there are biologics coming in now. So depemokimab, which lasts for 6 months, and that might be a preference for some patients because they only need to then be dosed twice a year. So the next case here, this is a much older man, maybe typical for most of my other patients. So he has adult onset, atopic and eosinophilic asthma. And he's steroid dependent for many years. So on maintenance Preda between 5 and sometimes up to 15 milligrams a day. He was also quite heavy smoker in the past, so 20-pack years. And like all our asthma patients, he's on high dose of inhaled steroid therapy, a LABA and a LAMA. He's also got nasal disease. He's obese. And then I've listed there a number of steroid-related comorbidities. Actually, I should have put obesity in that bottom box there. But anyway, he's got OSA, he's become diabetic, he's got reflux, and he's developed cataract. So a whole array of these comorbidities that are very, 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 very common in our patients. His lung function is really bad. As you can see, very marked airflow obstruction there. And then his CT scan shows a lot of mucus plugging. So, bronchial wall thickening and all this nodularity. And sometimes you'll get a new radiologist will come and go, oh, there's a nodule there, you need to follow it up. But actually it's all just mucus that's just sat in their lungs. And despite the duration of his disease and his steroid usage, there wasn't any significant bronchiectasis and no emphysema. So what about mucus and asthma? And actually this is something that we're learning more and more about now. So they've when you get a CT scan, they started to do, you can score it based on the amount of mucus plugs you have. So you can give it a mucus plug score of 1, 2, or 3, or low, medium, and high. And they've looked at that. This is I think, data from SARP, so the Severe Asthma Registry in America. And they've divided them up into either no mucus, which is green, blue is low, and orange is high. And you can see the higher your mucus plugging score, the worse your lung function. So they have lower FEV1, lower FVC, and the ratio is also lowered if you've got high mucus. Mucus is also very closely linked to T2 inflammation. And here you can see the higher your eosinophil count, the higher the mucus score on CT scan. And mucus plugs are even more common in people who have severe asthma compared to non-severe asthma. And the more mucus plugs you have, the greater your risk of exacerbating needing steroids. So mucus plugs is now this big thing that is that we try and target, we try and treat, and now we're looking at for it more and more. And this is where I'll just bring back the whole thing about tezepelumab. So by blocking TSLP, as I've shown you before, it can reduce FeNO, but by then sort of reducing the levels of all of those key cytokines, it seems to have, at least in terms of clinical trials, a very significant impact on mucus plugs and mucus plug scores. And they've shown that in one of the phase 2 studies with tezepelumab, where they looked at CT scans pre and post a period of tezepelumab, and there was a significant reduction in the mucus plug scores on these scans in these patients compared to placebo. So if we come back to my patient here, you can see, and I've just tracked his progress. So when tezepelumab was started, 6 months in, and then 12 months in. And as you would expect, his eosinophil count came down, his FeNO came down. But look at that improvement in that lung function. So this is a man who's in his 70s, who smoked for 20 years. He's had asthma for years and years, very poor lung function to start up with an FEV1 of 1 liter. After 12 months, that's improved by sort of 500 mils, so half a liter of improvement. His steroids have come down. He's had no exacerbations. And the other responses as we would expect with the biologics. So I'm not overly surprised. One of the things that we always think about, or patients always ask us, and often the referral letters go, oh, they have a lot of triggers. And here, this is just showing you, this is UK data on the different triggers, and the bars are showing you how the proportion of patients that reported that as triggering their asthma, and the dots are showing you the number of weeks in the year that they reported it. And by and large, I mean, dust is the biggest trigger. And you think, does it matter if the triggers are allergic? Does it matter that the triggers are non-allergic? What do I target? And luckily they have looked at that now. So this is tezepelumab, and they've broken down response to treatment by trigger. So whether it's things like exercise, or whether it's things like air pollution, or the more typical allergic triggers, so dust is in there, and seasonal allergies in there. Regardless of the trigger, the biologic is beneficial. There's a significant, so over 70% reduction in exacerbations, regardless of the trigger that the patient is reporting, because we're treating the underlying immunology. So in summary, I will say the management of patients with severe asthma has really advanced, and it's advanced through an understanding of the underlying immunology. When you look at your patient, use the biomarkers when you're phenotyping them and think about it. Are they T2 high? Are they T2 low? And if they're T2 low, go back and think, what was it historically? Were they T2 high in the past? Did they have that signal? And biologics are transformative for the right patient. They improve all measures of disease control. And really importantly, they reduce steroid-related side effects. And I'll end just with a picture of our entire asthma team in my center. And as you can see, it's not just one person. It takes a whole team to have this sort of work with our patients and improve their outcomes. And I'll end there.
Thank you, Dr. Hitasha Rupani, for your lucid presentation, and your message is loud and clear, saying that one size doesn't fit all. You have to go for a personalized medicine. All the three speakers have completed their presentations. Now the session is open for question and answers. There are 3 microphones there. If anybody want to ask question, introduce yourself and be brief.
Keith Hathatur, I work in UK too. So it's very interesting. We got Professor Denning as well as Hitasha here too. And you can see now we got a problem here with asthma, and they're getting worse. So now, as you mentioned, SAPs and ABPA, what are we going to do? We'll be hitting them hard with high inhaled steroids, and some of them we might not go to high dose Relva. And then we realize, oh, he's got ABPA. Let's start him on some itraconazole as well as oral steroids. Or he might start oral steroids first and then itraconazole. Depends on the case. And the question now really is, and it applies to you also from the asthma point of view. So you got patients who are now on oral steroids, and everybody's worried about the adrenal suppression, particularly along with itraconazole. And do you actually drop the inhaled steroid to something like a MART regime?
So the way that I would approach these patients is that if you make a decision to treat them with itraconazole and they're on oral steroids and inhaled steroids, I'd bring the oral steroids down first. So I would probably drop the steroids within a month, 2 weeks or something. I wouldn't stop immediately because I want to know that the patient can take itraconazole and they're not coming off immediately. So it takes a little time. So I'd probably at the first visit at 1 month, I would then bring the steroids down and stop them. And in a little bit of work we did, phase 2, we were able to stop the oral steroids at 75% of patients. The next thing would be, what is the inhaled steroid dose and how do I approach that? And that would be the second step. And they will clearly need inhaled steroids. You have to carry on with inhaled steroids. There's no question. It's just a question of the dose. So if it depends really on which steroid they're on and how on. And I would bring them down to lower levels, but it would take me 4 months to get to a baseline level.
Yeah, so we have to say that we tend to be more proactive. Well, I guess in parallel, try and think about biologics. So as soon as they're starting to need oral steroids to manage their disease and they have asthma, there is a lot of real world evidence that the biologics are beneficial in that case scenario. And I get a lot of referrals from my bronchiectasis colleagues to give patients, and they respond really, really well. And really we found that it sort of just reduces that mucus plugging. And the sort of their secretion load comes down as well, which makes them feel better. So it's not just we reduce their steroids, they actually come back so that they feel that they can get that deep breath in. So we are trying to intervene before they get significant adrenal suppression.
One of the challenges I think we face is an economic challenge. And one of the things I've been very interested in my global health work in Africa is how would we treat severe asthma in a low income setting? And the cost of itraconazole, for example, in Kenya is about $600 or $800 a year. The cost of any of these biologics is $25,000, $40,000 a year. So I think there's an economic piece here about trying an antifungal. And if that doesn't work, going to a biologic. If you are in Southampton or you're in Boston, then you would go the other way around, I think. And I think it's a simple economy question, I think.
Well, let me thank all speakers for excellent presentations. My question is to Professor Denning. How would you approach a patient with serological evidence of ABPA but no bronchiectasis? And would your approach be the same? And in these patients' cohorts, how relevant is fungal sinusitis or involvement of the sinuses?
Right. So let me ask you a second question first. The value of antifungal therapy for patients with chronic or allergic fungal rhinosinusitis is not fantastic. There is a small group of patients with really recurrent, difficult sinusitis who seem to get better with oral antifungal therapy. Amphotericin washouts don't seem to work very well, but it's a very small subset of patients with chronic rhinosinusitis. That's point one. ABPA-S, which is the sero group of ABPA patients, there's less argument for treating them at all, actually, unless you're treating severe asthma. And I think if they're just immunologically diagnosed with ABPA and they have trivial asthma and they're controlled with inhales, I wouldn't give them itraconazole. I wouldn't do any of that. I certainly wouldn't give them a high-dose steroid for weeks on end. That would be the wrong thing to do, I think. So I think that's a phenotype that isn't very well studied because I think a lot of doctors just don't think it's worth studying. It's not important enough to study, essentially.
My question is to Dr. Hitasha. This is regarding when you have a discordance between the T2 biomarkers, when you have a low FeNO and a higher absolute eosinophil count, or else the other way around, then when you have a higher FeNO and a low absolute eosinophil count, when it comes to the choice of biologics, how do you make a decision in such instances?
That's a really good question. It's one that we talk about a lot in our MDTs, and I think there's no head-to-head studies. And I think what I've tried to show you is that there are biologics that they So if you target an eosinophil, you get a pan reduction in that inflammation within the airways. So if your FeNO is low, patients still benefit. And similarly, we found that patients that have a very, very high FeNO, but like a moderate eosinophil count, they respond as well. But with all the choices we have, you could pick another one. We review all our patients at 6 months, and if they've not really responded as well as we'd like them to, we switch them. But I take on board completely what Professor Denning said. We do work in a country where I can give them the biologics. I don't have to think about the cost, the significant cost implication they have. So I think if you get one to go, I would tend to go higher up on that pathway and choose something that is broadly targeting the T2 inflammation rather than being very, very specific.
So one more question. So regarding the use of biologics in asthma, so we only target the exacerbation as an endpoint when we are using the biologics. Why don't we target the other asthma endpoint like quality of life or lung function decline in making a decision on using biologics?
The honest answer is that it comes down to cost. It's cheap. It's a cost saving for the health economy if you reduce the number of exacerbations, because you also reduce the number of hospital admissions, and that's what's really, really costly. What I've not shown you is data on sort of unscheduled healthcare utilization. So when they go to see their doctors in emergency, when they go and call the ambulance, there's a cost saving across the board. Whereas for quality of life, there is no cost saving for a national health organization. What we are now starting to see is people, when they are on a biologic, they can go back to work. So they're not on they're now actively earning again, and we'll start looking at that. But I don't think there'll ever be an endpoint in clinical trials. It comes down to cost.
Thank you.
So what do you think about the long-acting biologics?
What was that, sorry?
The long-acting biologics that have just come in, what do you think about it?
So the 6-month one will be coming out soon. It's just went through the phase 3 studies, and I think it'll be good for a certain group of patients. If you think you can only need to be dosed every 6 months, it suddenly gives them their life back. They can go traveling, they can do all the things, their work if it's abroad. I think we'll have to wait and see. Some of my patients like dosing themselves every month. They feel that they've got their dose, they feel better, they know they're going to get it. For them, it's a routine, it's a treatment, they like that. So the 6 months will be a whole different thing, but there are different applications there. So if patients only get exacerbations in the winter months, you could argue that before the winter hits, you give them a dose and then you wait till next winter. So that there are different, I think we'll see that over the next few years.
So, hi, I'm Dilashini. I'm Senior Registrar in Respiratory Medicine. This question goes to Professor David. We actually had a real-life patient who had this nail fungal infection almost affecting all the nails. So, regarding the dermatophytes, so how long we can wait? That patient had difficult, very severe asthma. So, how long we can wait after starting antifungals to see the response?
So we normally treat these toenails with 6 months of terbinafine. That's the standard approach. Fluconazole actually works as well. Pfizer decided, they did all the studies in dermatophytes when they were developing fluconazole, and they decided the market was better to go for oral candidiasis or vaginal candidiasis because they could charge more. So all the dermatology studies have gotten forgotten with fluconazole. The improvement time with antifungal therapy with severe asthma is gradual over about 4 months. So you get some improvement within 1 month, but you get much fuller improvement over 4 months. And in fact, in some of our studies, even 8 months, you get further improvements. So the answer is that if you're going to treat toenails for 6 months, then you just treat and see how you go, I think. But some of the tinea pedis where you get, you can treat that, like severe athlete's foot, for example, or ringworm, you can treat that in 3 months or 6 weeks. That it's a much shorter therapy for those patients. So it isn't always onychomycosis, actually. It's these other things as well.
Thank you. I think we are running out of time. In the interest of the time, we'll close this session. I must thank all the speakers for excellent elaboration on these various topics. Now is the time to present the certificates.
Thank you. As we conclude the first symposium, it's time to appreciate our distinguished speakers. So let me invite our chairpersons, Dr. Keerthi Gunasekara and Dr. Subhakar Kandi to hand out tokens of appreciation and certificates to our esteemed speakers, Professor Pudupakkam Vedanthan, Professor David Denning, and Dr. Hitasha Rupani. Thank you. I extend my heartfelt gratitude to our esteemed speakers and the chairpersons.